Yeah, hi. I'm Richard Betts. Been called to a 42-year-old male. Patient has a history of asthma, has also been having a productive cough, and has used his inhalers to no effect. Coming into the scene, I'm looking at the patient. I'm going to introduce myself to the patient. So, hi, my name is Richard. Work with St. John Ambulance. What's your name?
Fred.
Hi, Fred. Can you tell me, Fred, what's your date of birth?
Date of birth 24th of the 6th,
Okay,
1970.
Okay, Fred, I'm going to be obviously going to be assessing you and seeing what's going on. Are you happy with me to assess you, to touch you, and even to expose your upper body?
Yep.
Okay, great. So far I've determined that obviously the patient is able to, he has a normal level of consciousness. He's able to speak full sentences. So he's getting three, four words per breath. So he's not too compromised in his breathing. Also, what I've established is also in looking at the patient, I see that he's not cyanosed, he's not blue in color, he's a normal color, he's not clammy, and that we can continue on with our examination without having to quickly get off to hospital. So now, as I go back to my assessment of Fred, I'm just going to ask Fred, Fred, are you having any pain anywhere?
No.
No? Is it hurting more when you take a deep breath?
Not really.
Okay. So I've just wanted to establish, if this is more cardiac or a respiratory issue. He's not seeming to be too distressed. His color is not cyanosed. Also, I'm looking at the environment around Fred's bed, and I do realize that there is inhaler on his table next to him, and he's told me that even though he took his inhaler, it has not improved his breathing. I'm just going to start inspecting Fred, and I'm going to start from the head, and I'm looking, first of all, as I said, I've seen his color, but I'm going to just ask Fred, can you just lift your tongue for me? And I'm looking at the color under his tongue, because if somebody's peripherally cyanosed, it's a good indicator, and looking underneath the tongue. I'm going to be also looking at just how in his breathing, if he's in drawing, using auxiliary muscles, even in his neck. And I'm also looking to see if his jugular vein is distended. I have him just turn his head to the 45 degrees to the side, and just to look to see if the jugular vein is distended there, which could indicate that there is either increased intrathoracic pressure, maybe from pulmonary embolism, or even potentially something to do with his cardiac output that's causing that distension. I'm also going to be looking at his trachea, to seeing if there's any if it's been pushed over to the side. Again, could be because of an increased in thoracic pressure that's pushing that up, even from a cardiac tamponade. So I've looked at his head and his neck. I then go down into his chest, and I'm first just looking to see, well, as I noted earlier, just his words per breath, and also just looking at the shape of his chest. Typically, if somebody has emphysema, they tend to have what's called a barrel chest, which is just that is from time of trying to keep from being too overinflated. I'm looking for scars. I'm looking for any kind of anything that would be asymmetrical. So I'm looking to see, even as he takes a deep breath, assessing to see if the chest is rising equally, both on top as well as on the bottom. And I would do the same on the back later on, as I would inspect his back. So I'm looking for that equal rise and fall. I'm just looking just his working. How hard is it his working just to in his breathing? If he's even using those intercostal muscles as he's breathing. I'm going to have a look at your hands, and in his hands, I'm looking again for just color. If there's any cyanos, at that time, I would also be taking his pulse, getting a feeling again, obviously the rate. But also beyond the rate, also if it's bounding, if it's thready, if he has a just if he has AF or a heart rate that's changing its rate. So anyway, once I've looked at his hands, I'm going to then look at his just his back. And as I go to his back, I'm going to bring him forward. Again, I'm looking for any kind of trauma, looking for any kind of discoloration, and even some sacral edema that might be from the back, which would lead more to cardiac output problems. I'm going to then move to just auscultating the patient, and I'm going to auscultate first in the front, and then I would also do the back. And when I auscultate, I'm going to be listening in his subclavicles, above the clavicle, below the clavicle, and I'm doing it on both sides. And what I'm listening for is just to see if there's good air entry. I'm listening for the types of sounds that I'm hearing, when it might be rails, which would indicate just fluid sounds. I'm listening for rhonchi. I'm also listening for upper airway, if there was a stridor, some upper airway problems. I'm listening for pleural rubs, which could indicate even an infection there. Also for crackles in the lower lobes, which could indicate that there may be some pulmonary edema or even pneumonia. I've listened, auscultated in the front. Again, I would do the same on the back. And once I've auscultated, I would, as I've listened, I would also ask the patient to just say 99, because what I'm trying to listen for is to see if there's any vocal resonance. So if there was an increased sounds as in each place where I'm auscultating, if there's an increased sounds, it would indicate that there's some consolidation there, and potentially some, it's a higher density, more of a dull sound there. So once I've finished auscultating front and back, I would then go to percussion, same places. So we're going to percuss above the clavicle, below the clavicles. And again, I'm listening for dull sounds or resonant sounds. It would be normal sounds, but if it's dull sounds, that's indicating that there could be that there's fluid, or it could that it's more of a dullness. Also on the sides and in the lower. Okay, again, I would have the patient sit forward, and I would do percussion in the same locations on the patient's back. Now I've come to the conclusion of my examination of the patient, and in my assessment of the patient, I've ruled out different possibilities of problems, and really come to the conclusion that the patient has, even as I've done other observations like his blood pressure, temperature, saturation levels. I've found that the patient is febrile, and at this time there's no indications that he has having his asthma attack, but having a chest infection highly increases his risk for an exacerbation of his asthma. So I would transport my patient to hospital. I have a medium acuity as a status 3. Thank you.